Hello, I'm Rob Ward, the Chief of MSK at Tufts Medical Center, and I have the distinct pleasure today to introduce Dr. Elizabeth Matzkin, who is the Chief of Women's Sports Medicine and the Sports Medicine Fellowship Director at Brigham and Women's Hospital, as well as Associate Professor of Orthopedic Surgery at Harvard Medical School. Dr. Matzkin will be talking about gender differences in sports medicine today. Dr. Matzkin.
Thank you. Thank you for the invite to be here today, and I look forward to sharing some information. This morning, I'm going to spend a little bit of time talking about sex differences in common sports injuries. And when we often talk about this and we define athletes in sports, we're not just talking about professional athletes or collegiate athletes, but anyone who's active in male, female, and all shapes and sizes. I don't have any disclosures that are pertinent to this talk this morning. So my goals are going to be to discuss the role of sex in sports medicine. We'll go through a whole bunch of background data. We'll look at a little bit of some injury-specific data and then the clinical impact. And throughout, I'm going to talk about some of my research and how this has kind of been near and dear to my heart. So first and foremost, when we talk about sex in sports or in orthopedics in general, we need to define the differences between sex and gender. And sex is defined by genetic and biologic characteristics. So male and female are sex categories, whereas gender really refers to how each individual decides to live in society. So masculine and feminine are gender categories. So throughout this talk, we are talking about sex differences, and throughout all the orthopedic research we see, it should really be based on sex and not gender. So this first study is looks at the dearth of sex differences research in sports medicine. So Title IX was passed in 1972, and we'll talk a little bit more about that later on, but females participate in sports since then, but their kind of inclusion in any of the research that we've looked at has been pretty sparse. This article was published in 2018. And in 1993, the NIH passed the Revitalization Act, which mandated the inclusion of women and minorities in clinical research. In 2014, the NIH developed new policies requiring all researchers to report their plans regarding males and female cells in animals in any of their research data. It didn't mean that they necessarily always had to look at sex differences, but they needed to at least state that they thought about it and could simply state that sex differences weren't looked at. But the NIH really in 2014 made it imperative that we started thinking about what the roles of sex plays in all research, not just in sports or orthopedics. In 2014, there were several editorials, the most important one being in Core, that stated that all research should address sexes and should be sufficiently powered to analyze the influence of sex. So there's still a dearth of this in our literature, but we're going to try and start to fill some of those gaps, and we're going to talk about them today. So this was a review article that we published. I think I shared it with everyone that looked at sex-based differences in common sports injuries, and this really kind of summarized what we know to date, or what we knew up until about 2018 about some of these sex differences, and we're going to delve into these in more detail. So first, if we look at pediatric sports injuries, looking at different studies, females have a higher rate of overuse injury and lower extremity and spine injury. Pediatric males have a higher rate of traumatic injury and upper extremity injuries. Sex differences have also been seen in patellofemoral pain, with it occurring more often in females, osteochondral defects, more common in males, and fractures tend to be more common in males. As we move from pediatrics to high school, girls tend to have a higher rate of injury with regards to exposures compared to boys, and girls have a higher rate of injury in track and field hockey, especially of the lower extremity. And in boys in high school, we see a higher rate of shoulder injuries in swimming. As we continue to look at high school athletes, again, rates of injury are higher in males with regards to shoulder injuries, most commonly in football, wrestling, and swimming. And if we look at stress fractures, they're higher in females, especially in sex comparable sports, most commonly cross country when we compare males and females, but also in girls gymnastics. When we look at ACLs, and we're going to spend a little bit more time on this a little bit later on, but in sex comparable sports, girls had an almost 9 times higher rate of ACL injury compared to males. We see a very high incidence of girls in soccer, basketball, followed probably by softball. Boys have a higher rate in football, but girls don't play football, so we don't have comparable numbers. But when we look at comparable sports, the risk is much higher in our female athletes. When we look at some of these studies that looked at young adults with soccer, females had more knee capsule ligament injuries that included ACL. Males tended to have more thigh muscle and tendon strains, so rectus femoris and hamstring injuries. When we looked at skiing, males had a higher rate of injury than females. And when we looked at athletics in Europe, 14 international competitions, the injury rates were higher in males. Males again had higher rates of kind of thigh and hip injuries, and females had a higher rate of stress fractures. So this study by Aaron and Dick in 1995 was probably one of the landmark studies that really started looking at sex differences in sports injuries. And this was the landmark study that really started to note the difference of ACL injury in our female athletes. And there have been several studies looking at our NCAA athletes after that. In general, injury rates are higher in our female athletes. When we start to move into our young adults and our collegiate athletes, we can look at rugby. If we look at females, they have a higher rate of ACL injury. Males have a higher rate of fracture, AC separation. And I threw this study in there looking at vitamin D levels in our Division I athletes, where males have an increased risk of low vitamin D compared to our female athletes. So this was just a very general overview of some of the data and literature that we have looking at sex differences. And this really, I think probably ACL sparked my interest in, what can we learn from this and how can we make this better? And with the dearth of literature and research looking at this, 10 years ago when I started my practice here at Brigham and Women's Hospital, I also started collecting data on all my surgical patients. And so all my patients sign a consent when I see them, and they agree to answer basically outcome scores that get emailed to them at preoperatively 6 weeks, 3 months, 6 months, 1 year, 2 years, and 5 years. And so over the last 10 years, we've been able to collect enough data. It takes a long time to have 2+ year data on large numbers of patients that we can start looking at some of these sex differences in the surgeries that we perform and their outcomes in males and females. One of the first questions we asked was, does sex really matter in orthopedic care? And we surveyed about 6,000 American Academy of Orthopedic Surgery members. And we asked them about these 10 different common things we see in orthopedics. So scoliosis, ACLs, hip fracture, distal radius fracture, shoulder instability, hallux valgus, patellofemoral, knee osteoarthritis, Dupuytren's, and FAI. And we basically asked if they felt that there were differences in any of their diagnosis or treatment decisions or algorithms if they're treating males or females. And basically what we found was that really there were no differences that most orthopedic surgeons thought about, and the ones that did think about it had been in practice longer and actually tended to be male. So either there's just not enough awareness, or we just didn't find it important enough, but to really make it matter when we completed this study. We also did a study to look at how many of the papers and abstracts presented at the American Academy of Orthopedic Surgeons annual meeting over a 7-year period even look at sex-specific analyses. And only about 5.4% of papers presented during that time even reported anything about sex differences in the research. And the majority of these were either ACL studies in sports medicine looking at sex differences, or they were research that looked at the gender-specific knee that came out during this time period in total joint arthroplasty. So again, we really lack a lot of publication and data on this. This was a study that we review article looking at the female athlete triad, and this is where a lot of the sex differences also start. So again, Title IX was passed in 1972. About 20 years later, in 1992, a bunch of physicians got together after noting this specific triad that they were seeing in their female athletes and wrote about the female athlete triad. We've now kind of moved to new nomenclature, and instead of calling this the female athlete triad, we refer to it as relative energy deficiency in sport. And that's because, one, it can also affect our male athletes, clearly not as commonly, but it can affect male athletes, and they can see, rather than menstrual dysfunction, but changes in their testosterone levels that can also affect their bone density. But the main important thing that we need to understand is that it's the relative energy deficiency or the impaired energy availability that really leads to hormonal imbalances that affects our bone density. And this is really important in our high school and collegiate athletes because we can only build our bone density to maybe the age of 25 if we're lucky. And whatever bone density we don't build by then, we can never get back. So if our athletes aren't filling their bone banks to the fullest, they're going to really struggle with osteoporosis and fragility fractures later in life. So recognizing this and recognizing female athlete triad or RED-S is really important, and it's probably more prevalent than we think. In some of the research, we've noted that low energy availability is seen in over 36% of all of our high school athletes, 63% of our endurance athletes, and then 77% of our ballet dancers. When we look at menstrual dysfunction, again, 54% of our female high school athletes have some form of menstrual abnormalities, and bone impairment, 45% in our endurance athletes. And this is really concerning if we're not making our physicians, our athletes, our athletic trainers, our coaches aware of this, because their bone density will be affected later in life if we're not addressing this low energy availability. This was a study. We looked at over 600 female athletes participating in NCAA Division III sports, and about 30% had at least one risk factor of the female athlete triad. So again, it's been very hard to understand the true prevalence of this, but it's probably more common than we think. When we asked about female athlete triad awareness amongst physicians, we surveyed almost 930 physicians at academic medical centers in the Boston area, and only about a third could identify or knew what the female athlete triad was. So if we can't increase awareness of this, it's going to be a problem for a lot of our athletes down the road. And I think the biggest thing is that if we see an athlete, especially in orthopedics, with a stress fracture, we have to be asking about their nutrition, their eating habits, whether or not they have some energy abnormalities. We need to ask our female athletes about their menstrual cycles, because we can treat the stress fractures pretty easily, but we're not treating the underlying problem if we're not addressing those other things. So bringing awareness to this, especially for our female athletes who are playing sports, is going to be very important. I'm going to spend a little bit of time looking at specific injuries, and we'll kind of start from the head and work our way down. But concussion, we did a review article. I think it'd be a good time about now to repeat this, as there's been a lot more studies looking at these sex differences. When we did this review article in 2016, there were sex differences reported in many different studies, but there was a lack of consensus and looking at different types of patient populations to draw any real meaningful conclusions. But I think that there's going to be differences in how our female and male athletes present with concussion, how long concussions last, and how they return to play. We did look at our women's ice hockey players. Now in women's ice hockey, it is somewhat different contact. I don't like to use the word non-contact because there's still a lot of contact compared to men's hockey, but the risk of concussion in our women ice hockey athletes was really not very different. Almost 50% of our NCAA women's ice hockey players reported at least one diagnosed concussion during their career. And part of the concern when we start to look at this is that 80% of players, even though they thought they may have had a concussion, either don't disclose it and continue to play, mostly because they don't want to be taken out of the game. So there is a high incidence of concussion and a concerning level of symptom non-disclosure. So this is just another area in sports medicine where we need to make sure that coaches and athletes and athletic trainers and players understand the consequences of non-disclosure, as concussion needs to be treated and managed, and they do need to take a break from play. When we look at shoulder, and I mentioned earlier, there is a male dominance regarding anterior shoulder instability, and this has been shown throughout the literature in many different places. There's also a risk of recurrence of shoulder instability in males compared to females. We know that males present to the emergency department 2.6 times more often than females with traumatic shoulder dislocations. And again, the incidence of recurrent instability is higher in males and also higher in our younger athletes. So it's inversely proportionate to age. When I started looking at the literature to try and understand sex differences in outcomes after arthroscopic Bankart repair, the majority of studies that looked at outcomes in Bankart repair didn't even mention males and females. If there were 100 patients in the study, it never mentioned how many were male or female. And the ones that did, the numbers were very skewed. So we tried to look at as many female patients as we could, and even our numbers are very skewed in this prospective study. We had 281 patients and over 200 were male and about 75 female, which is actually quite a high number in the orthopedic literature for now, and hopefully we can get that number to grow. But we looked at outcomes and all of our different outcome scores. Females tended to have a lower mental health subscore, but they also reported that their treatment exceeded expectations at 2 years regarding motion, strength, function, and normal sports activities, more likely than males. Overall and in general, arthroscopic Bankart had similar outcomes for both our male and female patients. When we look at sex-based differences in rotator cuff, it was somewhat of a similar pattern. Females reported greater pain and decreased shoulder function compared with males during the first 3 months, but at 1 and 2 year follow-up, there were no sex-based differences. So women tended to have or struggle a little bit more in the beginning, first 3 months after rotator cuff repair, but when all was said and done, both our males and females tended to do just as well. And actually, there was a study that's just about to be published that I don't know, may be of interest to some of you who tend to read a lot of MRIs of shoulders, but there was a study looking at rotator cuff tears recently that noted that patients that were obese and female patients tended to have more fatty infiltration in general compared to males, especially if you looked at similar size tears and similar chronicity. So there is now going to probably be a boom in research looking at fatty infiltration in females and seeing if that plays a role in our outcomes in any way, shape, or form. When we do AC joint reconstruction and we quote unquote do an anatomic surgery to restore our conoid and trapezoid ligaments, the majority of the techniques tell us where to put our tunnels for those ligaments based on the distal end of the clavicle, and you measure in about 25 millimeters. And we know that these AC joint reconstructions fail when our tunnels are too medial. And I noted in some of the papers looking at failures, there was a higher failure rate in our females. And I wondered if this was because our females don't tend to have the same size clavicle as our male patients. And when we do these surgeries, perhaps we should be using a ratio versus just a strict measurement. So we looked at a whole bunch of clavicle x-rays and basically looked at 200 from males and 200 from females and made these different measurements to understand where those tunnels really should be. And clavicle length was definitely correlated with the distance from the lateral clavicle to the lateral edge of the coracoid. And the trapezoid tunnel was noted to be about 22 millimeters in our female athletes and 26, or not athletes, in our female patients versus 26 in our male patients. And similarly for the conoid tunnel. So sex-based differences are found in the position of the coracoid relative to the lateral edge of the clavicle, which means that when we do these surgeries, we probably need to adjust our measurements and our tunnels accordingly. This was a nice paper that looked at shoulder and elbow pathology in the female athlete and the different sex-specific considerations. Generalized joint laxity, or Ehlers-Danlos, tends to be higher in our females. Multidirectional instability along that same line. Females tend to have more capsular laxity. Distal biceps injuries are more common in our males. And as we talked about in the knee osteochondral defects, in the shoulder and elbow are more common in our male patients. There's been a boom in looking at sex differences in hip recently. Some of the papers in historically have demonstrated some of the sex differences. So males are more likely to have an osseous bump compared to females. Females normally have better range of motion compared to males if we look at the hip. And females have increased acetabular version, increased femoral anaversion, and a decreased lateral center edge angle. Cam deformity tends to be more common in males, bilateral FAI more common in males, and females have smaller alpha angles. So how does this help us treat our female athletes? I think we just need to recognize that large alpha angles may not be prerequisite to surgery, and our surgical techniques may need some modification. This was a real recent study in 2021 that looked at sex differences in clinical outcomes after surgical treatment of FAI. So some of the results demonstrated that male hips had a greater BMI and larger alpha angles. Females had lower pre and post-op scores, but greater improvement overall. So part of the reason I included this paper was just to demonstrate that this is becoming more prevalent, that we're starting to really try and look and discern some of these differences. If we go and talk about ACL, we already know that females have a higher rate of ACL tear, but females also tend to have poorer outcomes after ACL reconstruction. They're less likely to return to sport, and they're more likely to either re-tear their ACL or tear their contralateral ACL. So when we start to wonder what we can do about this, these are the studies that demonstrate some of that. I started asking myself, how can I modify my surgical technique to make ACL reconstruction better for our female patients? This study I actually included here. This was a systematic review. And what I found most interesting is there were 146 studies eliminated because the outcomes were not reported by sex. So this review was only allowed to include 13 studies because our literature and our previous research has not included a lot of the data that we need. Sex differences, this was looking at an MRI study. They looked at the ACL attachment location to see if it was different in males and females. And although no significant differences were found, I think these kind of studies and this kind of research is going to be really important to help us maximize our outcomes for our female patients. And so as I kept thinking about what can I do to make ACL reconstruction better for my females, what I noted is that females, when they have an ACL reconstruction, is they tend to get a smaller graft, mostly because females tend to have either smaller hamstrings or smaller patellar tendons or smaller quad tendons to use to make them a graft. So now we can take a hamstring or a semitendinosus tendon, and traditionally we would double it to make the ACL graft. But now we have found ways where we can quadruple it to provide us with a much broader or a bigger diameter graft to give our patients. And so in this study, there were 100 patients that no one received a graft less than 9 millimeters. In the literature, we know that grafts 8 millimeters or less have a much higher failure rate. And I am concerned that many of our female patients have been receiving grafts that are 8 millimeters or less, and therefore they've had higher risk of re-injury, higher re-rupture rates, and decreased rates of return to sports. So in this study, with providing our females with a graft that was not quite equal to our males, but all grafts above 9 millimeters, the average graft diameter for females was 9.4 and 9.8 for our males. But using this technique, functional outcomes were similar to males and females 2 years post-operatively. So we'll continue to follow this for 5 years, but hopefully this is one way we can start to level the playing field in our female athletes. We know that patellar dislocation and patellofemoral pain and anterior knee pain is more common in females. Trochlear dysplasia, patella alta, younger age and at the time of first dislocation, and female sex are associated with recurrent patellar dislocations. So again, trying to understand how we can prevent, treat, diagnose this differently in our male and female athletes is going to help us down the road. This was another study that looked at anterior impingement in the ankle joint in general and athletic populations, and just looking at whether or not sex plays a role. So there continues to be a lack of analysis looking at this, but people are becoming more and more interested, and I look forward to what we're going to learn in the future for sure. So when we think about all of this as a whole, how is this going to help us? Well, I hope it can help us prevent these injuries for all players, both males and females. I hope that we can learn to modify our surgical techniques to decrease the risk of shoulder dislocation after bank hearts in our young male patients, decrease the risk of ACL re-tears in our female athletes. Perhaps we need to modify our postoperative rehabilitation in these different populations. Psychological readiness to return to sport is also being looked at in a lot of these athletes. Fear of re-injury tends to be real. We are looking at resiliency scores in all of our athletes to see if that has any role in how they're doing after these surgeries and after these sports injuries. So we know sex differences exist. We have a lot of work to do with regards to looking at sex-specific analysis. We made a big push to have sex reported as an independent variable in all studies, including clinical, translational, and basic science. Our data is lacking, but I hope that we can continue to collect this data so that we can work to change and make our outcomes even better. So with that, thank you, and I would love to take questions and hear your thoughts on any of this, especially from a radiological standpoint.
Thanks, Dr. Matzkin.
Well, hi, Dr. Matzkin. I actually put a couple of questions into the chat box. I've been reading lots and lots of DEXA lately. And, you know, often when athletes, and I mean, these aren't child or collegiate athletes. I mean, more often these are people in their 20s, 30s. When they get stress fractures, they're often referred for DEXA. And I know that I have a macro for everybody who's either premenopausal or under the age of 50, that we don't use the WHO classifications, right? And we, they have to be less than or more than 2 standard deviations below the mean on Z-score to be lower bone mass than expected for age. So that seems, I mean, a really low bar. So, and in fact, I think it's very rarely that I see numbers like that, even though the T-scores can be, quite low. So what are you looking for when you order those tests in these people?
So it's interesting, and there's some controversy as to whether or not, I mean, is it DEXA scan what the data we really need when we're treating, a stress fracture in an 18-year-old high school cross-country runner? And probably not. I mean, what we really need is to get them plugged in to see a nutritionist. Often we will have them see endocrine just to make sure that there's no other reason for them to have any abnormalities that are affecting their bone density. But, someone who starts having multiple stress fractures perhaps will simply a stress fracture in a young athlete. We don't always jump to getting a bone density, but just trying to understand what the underlying problem is. And 90% of the time when you start talking to some of these athletes and you say, how is your nutrition? How, oh, I eat fine, and you ask them what they have for breakfast or, what they have for lunch, and a bag of Doritos and a Diet Coke isn't going to cut it. And, but often it takes some questioning and getting them plugged in with the right people. It is really important that these kids build their bone mass when they're young. And I think, perhaps trying to get to more understanding what those norms should be in those age groups will be important.
Thank you. Dr. Bradella has her hand raised. Mary, why don't you just go ahead?
Hey, hi. Thank you so much for this great presentation. I'm actually here at Mass General, so we are pretty close. And I'm doing a lot of research on bone in women with eating disorders or female athlete triad. And we have done multiple studies that have shown that the DEXA T-score or Z-score can be absolutely fine, but women still have impaired bone microarchitecture that predisposes them to fracture. We're looking a lot at marrow fat, which is an independent predictor of fracture risk and is higher, funny enough, in women with anorexia and female athlete triad. So I think the DEXA is a very crude measure, and what you said that they should just see a nutritionist and try to get their BMI up is probably more important than they're following their Z-score. And I just wanted to mention how important that is. And I was chairing an NIH study section the last 2 days on the topic was the intersection of sex and gender. But there was nothing on bone, unfortunately, no sports medicine.
Oh, well,
Thank you.
And I appreciate that. And I think I've always wondered, if in these athletes that aren't eating enough and how it's affecting their bone density, how it's also potentially affecting other injuries. I mean, does that weaken their ACL? I have no idea, but very interesting.
And a lot of them, the problem is that they do not want to gain weight. Gymnasts or ballet dancer, if you tell them you have to eat more, that's often hard because their weight is so important. Well,
I'm sure it's basic information, but when do they stop building bone? Just
by the age of 25, we maximized our bone density.
And then it goes down.
You hope you can maintain it for a while, but ultimately you're going to start losing bone density as you get older. And so if they're not building that bone density, they're going to be starting at a lower threshold and it's a problem down the road.
Right. I have another question. We had a lecture a few weeks ago from a friend and former colleague of mine, Greg DeFelice at HSS, who's at the forefront of ACL repair. And I know that he does repairs quite often in young athletes if they qualify as proximal tears. his feeling is they do quite well, at least 60% of the time, and it doesn't preclude a subsequent reconstruction. Do you think there's a role for that? Do you have personal experience with that?
I do think there's a role for it. I think it's very nichey though. And I think, having that perfect kind of ACL tear that peels off the femoral wall, there's probably a role for it. But, the majority of ACLs we see are, mop ends when we get in there. And I'm not sure that those are as amenable to repair. And it's always hard when we have a surgery that, does quite well, and we're trying to make it better and better and better. But I do think there's a role, and people are now supplementing repairs with, an internal brace, or putting almost like a ribbon or a fiber tape alongside of the ACL to give it some more support. And I don't know how much you know about the bear technique, where they're now taking a scaffold and putting it around the ACL fibers to kind of help them heal back in. So there's a lot of things happening. I still think the mainstay is going to be ACL reconstruction. And I think focusing on making sure that we're giving our female athletes a robust enough graft to give them a good chance is going to be very key.
I had always understood that the hamstring graft was more cosmetic than the patellar tendon bone autograft, and that's why women were given hamstring grafts preferentially. Is that not true?
I would say, one, it probably depends on the surgeon's incision, regardless of graft choice, but you can get a hamstring through a smaller incision. I am a big fan of hamstring grafts. In the biomechanics lab, they are actually biomechanically stronger than a patellar tendon. That being said, I think, depending on what you're most comfortable with using, and really putting it in well is going to be the absolute most important. But I find now I can quadruple a hamstring and get a much more robust graft than I can with a patellar tendon.
Very good. Does anybody else have any questions before we wrap up? I think we've done it. Thank you so much. This was very, very interesting, very informative. Thank you.
Thank you all, and have a super day.